Hello and welcome. My name is Jeff Taylor, and we're here at the 25th CROI in Boston with Dr. Seema Desai from Rush University in Chicago and Dr. Alan Landay from Case Western.
No, from Rush.
I said from Rush as well, I'm sorry. I don't know why I do this every year.
I've moved affiliations, but not yet.
Okay, so both from Rush, and thank you so much for joining us again this year for our annual chat about HIV and aging. It's 25 years into the epidemic, and the good news is people are living longer and for the most part better, but there are still challenges we face. So, and there's been, a lot of information at this conference. Every year there's more and more about not just the clinical aspects, but interestingly this year the kind of psychosocial aspects of aging. So what stood out for the two of you in terms of...
So there was a lot of presentations on psychosocial aspects, as you said, and to integrate mental health and, for better quality of life. Now that we know that life expectancy has increased and extended, you want to make ascertain that the patients live better quality of life and that there is an integrated approach in HIV medicine to taking care of all these other aspects, the biobehavioral aspects, such that there is some return to health with control of the virus and extension to life, Besides that, there were also many presentations that looked at interventions, like especially cardiovascular, which was made by Priscilla Shu on low-dose methotrexate, and that showed reduce immune activation.
And that's not a new drug, is it?
Yes,
it's been around for a while.
Right. And it showed that it also reduces Ki-67, which is like the cell turnover marker. And so it was encouraging to see that. There were a lot of work presented in the START trial, the DAD trial, that showed life expectancy was increased, but also that it was associated with markers of inflammation, which we already know of. Right. So I think the takeaway is that now that we know that there is increase in life expectancy, which is also associated with inflammation activation, I guess there has to be more effort on intervening these pathways that result in comorbid events and improve quality of life is what I think.
I think one of the newer concepts I came away with this meeting was moving from a concept of lifespan to health span. I think that's telling us that, it's not just living longer, but it's living healthy and living well. We're seeing aspects of frailty and impact of our aging HIV population. We want to really make, and as Dr. Desai said, mental health also being there. So we want to be healthy physically and mentally as we're aging with HIV and seeing that in the population. I think we're also looking at a lot of the interventions is understanding more about what are the right populations to study, because many of the people are healthy, their immune markers are normal. It's not that everybody has increased inflammation or activation. So I think in terms of, we've looked again at a lot of the targets of inflammation, and what we show is we don't really see as dramatic effects as we might, and it may be more related to the patients we select for that. We're selecting people whose virus is completely suppressed, probably for up to 10 years. We're selecting people whose CD4 cells are over 500, so very healthy immunologically. And those people are doing well on therapy, and they're probably going to live well and may not develop as severe of the non-AIDS comorbidity. So I think in order to understand who do we target our anti-inflammatory therapies towards is those populations who really need it. And we need to understand more about the role of the virus in inflammation. I think that's something that I came away with. A lot of people were asking is, well, how does inflammation affect the HIV reservoir? And so this really provides an important intersection of the aging agenda along with the cure agenda. Because as we think about moving forward in our cure questions and interventions, these are going to be in people over 50 or even probably 60 years of age. So we have to ask about the aspects of aging and interaction of fields, and I think that's another thing I came away with. As we've always said, we just talked about methotrexate, an old drug from the rheumatology and autoimmune field, and I think we need to get cross-discipline interactions and work with our geriatricians. As we've said before, it's important for understanding that.
So I just want to add a bit. I think that people are aging, and we need to, I think, better the health of the aging population, and we need to take care of them, and just as any other chronic disease, and that they have. Integrated care is what I would suggest, because the plenary by Robert Ramian on integrating mental health into care was really encouraging to make these little changes that we have, where we target inflammation, we do immunology, we do virology. I think a more holistic approach and an integrated approach towards care of aging HIV population, I think is critical in improving their lives. And a health span, as Dr. Landay alluded to, is also I think going to be the next step towards bettering their lives.
Well, certainly one of the sessions yesterday talked about the importance of smoking cessation, which everybody knows, across the board is hugely important. But one of the challenges is that it's an addiction, and that's a mental health issue.
Yes.
And you can't just give somebody Chantix or a drug and expect it to work, because there's so much.
I'm glad you brought that up, because I think across various presentations, smoking cessation added years to life. So it's very critical that these biobehavioral pathways are addressed in a way that you can intervene them to, if it was associated with chronic kidney disease. Even in the presentations related to aging, they said to address smoking cessation. So I think if you address these biobehavioral pathways, which add multiple comorbidities, if you intervene them, maybe we can take care of some of the comorbidity burden. I think so. And I really look forward to a better effort in taking care. As I think across the presentation, it came to me that people are living longer, and now we know that they are aging, and that, inflammation, as you said, to target the right population. But cessation programs and lifestyle interventions are key, I think.
There is, I think, an importance. There was a strong focus on cardiovascular, but we need to look beyond that, as Dr. Desai just mentioned. Kidney disease, I think we're starting to see more of that. We know a number of the drugs we've dealt with, and I think this long-term toxicities that we've dealt with certain classes of drugs affecting kidney, affecting bone. What is that going to do to the populations that are aging? I think we're going to start seeing, as those individuals are reaching into their 60s and even maybe some 70s, we will see more long-term effects of aging and the drug toxicities and metabolic effects. Those are things that excuse me, come up in the meeting, but don't get as much attention in the whole inflammaging arena. I think also looking at sort of the global health questions of aging, one of my colleagues mentioned osteoarthritis. And is that something that we really haven't thought about? We talk about bone and fracture, but what about joint changes? And that's going to affect mobility, it's going to affect frailty.
And it's an autoimmune disease, so it's right back to the immune system, right? So.
Right, and so I think we have to consider that in our aging HIV population. So maybe in the meetings to come, we'll be looking at other comorbidities as we're recognizing these cohorts. And I think what also comes up is, as we look at the developing world, like the US or Europe or Australia, maybe different in our aging or outcomes than are in the developing world, like Africa. And we talk about the immune system. We've recognized two parts of the immune system, the innate immune system and adaptive. And we've come to understand that a lot of the cardiovascular, diabetes, neurocognitive may be more innate driven, one of the immune cells called the monocyte macrophage. But when we look in Africa, for instance, we're seeing it may be another part of the immune system, the adaptive immune system, that may be more relevant. And there it's T cells that are still there because related to cancers and other outcomes of infection. So those might be more relevant in some of those studies related to inflammation. So I think we have to recognize how we treat, how we approach this disease is going to be different on a global basis for aging.
And are there any clues emerging as to what drives that geographical difference in the immune system? in people living with
Well,
HIV?
I think a lot of it may be the co-infections. You have tuberculosis, you have parasitic infections, so you have other things, malaria.
Right.
And I think one of the things we've talked about before is diet. And what does diet do to this outcome? Because the diets are very different.
Right.
And maybe the changing diet, that a agrarian culture moving more to a Western diet, a McDonald's on every corner in Kenya
Right.
or in Malawi. So now we're recognizing that the introduction of Western foods, high-fat diets, may also be affecting populations that aren't, where they've evolved over time for not having that kind of a diet. I mean, it affects us and the obesity and the weight gain that we have in our country also.
Exactly.
And looking at the impact of diet, and one of my favorite subjects, the microbiome, which is there and can clearly affect the outcome with regard to diet.
Was there any new information on the microbiome at this conference that stood out for you?
I think there was a little bit on some of the metabolic pathways that are coming up. I mean, we're focusing more in the microbiome. There was in terms of there was a poster discussion session around the microbiome, a lot of it more around transmission, and some about some of the new therapies. We had a probiotic therapy from the ACTG this year presented.
It was the Visbiome study, right?
Yes, the Visbiome study was there, although, again, results were not striking. This was the initial look at what happens in the gut tissue, where we hope to see reconstitution of the Th17 cells that are responsible for maintaining the gut integrity. We know about leaky gut in aging, leaky gut in HIV. We thought maybe Visbiome would repair that. Well, we didn't really see the evidence for that. We also saw a prebiotic study, so that's a probiotic. Prebiotic is really the food for our bacteria, and that was given by the group from Madrid, and again, not a real striking outcome. So I think we need to ask ourselves is, are we choosing the right patient population? May not be the wrong approaches, but we need to make sure we're giving these to the right patient.
Who benefits?
Right.
Yeah. And who's going to be the right benefits?
Well, in studying the microbiome, I mean, taking a pill, you have a huge, tract, and getting the right flora to the right place, I guess, is a huge challenge, and whether or not that's the right delivery system is a question as well.
So, as Dr. Landay said, there were studies from where we were at the last CROI, but I guess the target population is critical here because you're not seeing a very great significant difference. And probably this is just the start of it, and there needs to be some more work done. But certainly fixing the microbiome has its own merits and should be pursued zealously, I think so.
Yeah, and I think we're thinking about it, not just about the bacteria, but we heard from the plenary talk by Dr. Klatt that we're looking at how the bacteriophages might be used to treat and alter the bacteria. So we're now using viruses as therapeutics to get rid of bad bacteria.
Right. So there are good viruses as well as bad viruses.
Yeah, there are good viruses that might be useful, and I think it's a really fascinating and interesting new area to pursue, and how can we use these new agents to treat the dysbiosis that we're finding in the gut. And I think it'll have a lot of important implications, just not from the HIV field, but in general. I mean, one of the other things that hadn't come up, although we're still dealing with the other co-infections, so even as we treat HIV and are very effective, we still have other infections like CMV or HBV or HCV, and I know a lot of these things are going to be of relevance to our population, and how do we treat? We've done tremendously well in HCV. I think our next new target will be HBV, but that's still going to be a driver of inflammation. And CMV, we're well behind, and as Dr. Desai could probably tell you as well, studying that is an important part of our aging immune system in effect.
So to kind of go a little bit back, for all these intervention studies, I really would also like to have immune senescence as the outcome, because eventually your immune system gets senescent. So you want to know, like, for example, impact of microbiome on the immune senescence aspects, This is something that I would like to see happen, because that would take it a little beyond what we know beyond immune activation. And since immune senescence is really an aspect of aging of the immune system, you want to see that as an outcome to be studied as well when you're looking at viral load and CD4 as the outcome. You also want to look at the senescence aspect of the immune system to see how whether these interventions can indeed improve senescence.
Right.
And Dr. Desai brings up a very critical point, because in the field of aging we have what's called geroscience.
Yes.
So that's a term I think that's important to bring to the HIV world. People who work in aging have done a lot in their meetings devoted to aging, but we don't get the crosstalk, the people who are doing all this question of how to increase longevity, how do we enhance people's lives in the health span, as we just talked about, looking at some of these drugs that are there, and can we block the aging pathway. So I think we really need to learn from our colleagues in these other fields and to begin to think about how we can cross over. Some newer studies in the aging field, for instance, metformin is one of the newer drugs being looked at in aging.
Yes.
And so I think that's where...
And that's been studied in HIV as well, right?
Yes,
Yes.
it has been. So I think that's where we need to understand, and Dr. Desai made a very important point, is the biomarkers we're using maybe not the right ones. Maybe we need to look at others, because we're not seeing much of an effect. IL-6, not much change. Soluble CD14, just a little bit. So maybe looking in another cupboard, another area, we could find some newer biomarkers, and that really is an area of where we should focus some of our effort, novel biomarkers from the aging world that might give us insights in inflammation and immune activation.
I was struck this year that they had an entire session just on mental health, which I think is a first for CROI.
Yes.
And especially as we talk about people aging, as you said, we can affect their clinical outcomes. We have good drugs, we have good viral suppression and immune recovery, but it becomes the other psychosocial issues that affect the health
social
span.
isolation and mental health, depression, and I was very happy to see that included in the plenary session.
Yeah.
Yeah, it's a lifestyle. I think, first and foremost, we have to talk about the patient's lifestyle. What are they eating? How do they live? What's their environment? What's their social environment? As you've said, and Dr. Desai has said, social isolationism is just really a huge impact in our HIV communities, and many of the individuals do not have, support networks or support systems, and that is going to affect them and evolve in terms of just like PTSD kind of symptoms that you might develop. And I know Dr. Desai has worked in this field and trying to understand the impact really on the immune system, and that will give us some new critical insights for our patients.
I do think it is time that we work cross-discipline, and all of us work collectively towards addressing the aging question. It's because we've been working on immune senescence, but as you said, the biobehavioral pathways are so key to improving life, right? So how does intervening these biobehavioral pathways impact the HPA axis or the immune axis? We need to kind of expand our research to more translational benefits to the patients, and I think that's going to be key how this aging of HIV is kind of addressed. So I think all in all, bettering health of people, improving quality of life, better interventions, and looking at the right outcomes, like looking at senescence and learning a little bit more from the aging field, and driving the science more towards patient benefits, I think.
We have to treat the whole person.
Yes.
Right.
And I think that's the point today, is that when the individual is sitting before their physician, they need to be looked at as the whole person, not just here's the virus, here's the immune system, here's all the other social and other. You really have to think about this as in a holistic and integrated way to really make an impact. And I think by doing that, then the outcomes are going to be much greater and much better as we go forward.
Yeah, you touched on PTSD, which I think is kind of under-recognized as kind of a driver between behind unhealthy behaviors in people, and why, even though they're doing clinically well, have done well for so long, that especially in long-term survivors who've been dealing with this for 20 or 30 years or more, suddenly they kind of fall apart. And so there's a lot of unresolved grief. Some people have termed it AIDS survivor syndrome, just having lived through these horrible times, having lost a lot of their support system, their families, their friends and loved ones over the years. And as you said, that leads to isolation. So there's a lot, as a community, we need to deal with as well as the individual in terms of addressing those issues.
I think not than ever before, I think the community and the scientists have to come together. To address these key issues which should be integrated into research, as well as the researchers have to understand what the community perspective is about our studies, know. So I think together we can make better life.
Well, we did it at the beginning, right? That's how we got the initial advancement.
Yes.
And so it's going to be important again. Well, this is terrific. Thank you so much.
Thank you so much.
Thank you. This has been great, and I think next year will be hopefully some more exciting
data.
And
I look forward to talking to you then.
Great. Thank you.
Thank you, Jeff.
Bye-bye.